are bringing up again to our esteemed individuals this time around COVID-19 virtual webinar series, which will talk about COVID-19 and its vaccines generally. You'd agree with me that the incidence of COVID-19 has altered with our everyday living as individual, both on a local. The advent of COVID-19 vaccine brought some hope into the life of individuals as we're all very optimistic that it will curb the spread of these vaccines, and again, we can resume to our everyday activities rather. However, the speedy approval of some of these vaccines has thrown many into disbelief again as to questioning the safety and efficacy of these vaccines. So as such, we at C-Help have thought to organize this webinar series to educate individuals about this vaccine and its molecular makeup and how it can affect individuals. So as such, we've bring together experts from the field of medicine and basic scientific research, both locally and internationally. And to take us further, to start with, is Dr. Margaret Popola, who is a resident doctor at the Trauma and Orthopedic Surgery Department, and she'll be giving us an overview of this vaccine. So, Dr. Margaret Popola, thank you so much for joining us. Let it interest me to let you know that also that she's the executive director of CEOP Nigeria. So, thank you so much, Doctor, for joining. You have the stage now.
Thank you very much, Olalekan, for putting this webinar together. Thank you for all you do for C-Help.
Hi, Dr. Margaret.
Yes, I'm trying to share my slides.
Okay.
I don't know if it's affected already. Is it done?
No, I think somebody is sharing their screen. They have to stop sharing before you can share yours.
Okay, please go ahead and share your screen now.
Okay. Are we there? Please give me a few minutes.
Right. Well, thank you. We can see your screen now.
Unmute.
Hi, Dr. Margaret. You're on mute. Can you kindly unmute?
I think I'm on mute now. Hello,
Okay,
can
yes,
you
we
hear
can
me
hear you
now?
clearly. Yes, I can hear you. I can hear
Okay,
you.
I'm truly sorry. So good morning, ladies and gentlemen. Good morning, Nigeria. Welcome to this webinar series put together by C-Help Nigeria on the theme, COVID-19 and its vaccines. You agree with me that this theme is quite topical for the times that we are in presently. Before I go into my presentation, I would like to use this opportunity to express my appreciation to the facilitators of this webinar. In no particular order, I would like to say a very big thank you to Dr. Solomon Rotimi, who is joining us this morning all the way from Covenant University in Nigeria. Thank you so much, sir, for accepting to participate even at such short notice. I also want to appreciate Dr. Mohammed Sadiq, who is also going to be talking to us this morning, all the way from Sheffield in the United Kingdom. Thank you so much, Doctor, for accepting our invitation. We are most grateful. And of course, we want to specially appreciate Dr. Ephraim Akasi, joining us from the Lagos University Teaching Hospital, Lagos, Nigeria. Dr. Akase has been one of the frontline doctors working very hard in Lagos State to make sure that our people are safe. We thank you so much for all that you do for the people of Nigeria. I want to say a very special thank you to Dr. Pupuola Olayinka Benjamin, who will be presenting about the immunology of the vaccines during this webinar. He is a radiation and clinical oncologist at the Federal Medical Center, Gusau. We owe him a great debt of gratitude for all the numerous supports that he has given to C-Help. And most importantly, we want to thank him for making today possible. Thank you very much, sir, for all you do for C-Help. Last but not the least, I would like to thank Olalekan Oladimeji, the astute young man behind many of the progress that we have experienced in C-Help of recent. Thank you so much for all you do for C-Help Nigeria. I'll be presenting this morning on the topic, overview of COVID-19. My name is Dr. Pupuola Margaret Owoloyi, and I'll be doing that following these outlines from introduction through clinical features to the way forward. The year 2020 was unprecedented. It saw the emergence of a dangerous virus that spread rapidly through the world, causing a most dreaded pandemic called the COVID-19 pandemic. It threw the world into a panic. Efforts to combat the disease gave rise to new innovations in the social space, which we collectively refer to now as our new normal. It also gave rise to extensive collaborations in the area of research, culminating finally in the development of effective vaccine as we have it today. What exactly is this COVID-19? COVID-19 simply means coronavirus disease 2019. The appellation 2019 is important because coronavirus is actually not a new disease. It's been with us for several centuries. However, this newly discovered virus has to have the tag 2019 to it to differentiate it. The name coronavirus is derived from the Latin word corona, meaning crown or a wreath. It is also a borrowed word from the Greek language, the word koron. The name was first coined by two scientists, June Almeida, and David Tyrrell, who were the first to observe it and also to study the human coronavirus. The coronavirus disease 2019 is caused by a new strain of coronavirus, SARS-CoV-2, that has not been previously identified in humans. SARS-CoV-2 simply means severe acute respiratory syndrome coronavirus 2. The coronavirus 2019 was first reported to World Health Organization on the 31st of December 2019 in Wuhan, China, where there was an outbreak of this condition in the seafood market in Wuhan. Barely 30 days after that outbreak, precisely on the 30th of January 2020, the WHO Director General, Dr. Tedros Adhanom Ghebreyesus, declared the COVID-19 outbreak a public health emergency of international concern. That declaration was WHO's highest level of alarm, a rallying call to all countries to immediately take notice and take action. And this was very important because countries looked to the World Health Organization for guidance on how to tackle such global health concerns. It simply meant that at this point, the COVID-19 outbreak had assumed the proportion of a pandemic. The last time the world saw a pandemic was about 100 years ago, and that was the influenza virus pandemic. By the 27th of February, which was barely 2 months after the declaration of the pandemic, Nigeria saw its first case. The very first case of COVID-19 arrived in Nigeria from Italy. By the tail end of March, going into April 2020, Nigeria, most states in Nigeria were in lockdown. In other climes, in the more developed climes, people were already in lockdown before that time. By August 2020, about 1 million cases were already confirmed on the continent of Africa, despite the low spread and testing. The world was afraid for Africa because of the weak health system. With a population of 1.2 billion and weak health infrastructure, experts feared that COVID-19 would severely impact the entire countries in Africa. However, it turned out otherwise. Many factors have been proposed, though not confirmed, for these reduced numbers in Africa. The first confirmed death from COVID-19 was declared on the 9th of January 2020 in Wuhan, China. Barely 22 days after that, the first death outside China occurred in the Philippines on the 1st of February 2020. And exactly 13 days after that death, the first death outside of Asia occurred in France on the 14th of February 2020. As at this morning, on the world stage, the global update tells us that we have a total cases of 116,697,704 cases of coronavirus globally, while the death toll stands at 2,592,527 deaths. The good news, however, is that a total of 92,307,600 patients have fully recovered from this disease globally. On the local scene, as at 29th of December 2020, we had a total confirmed, we had a total number of confirmed cases at 85,560 cases. And of this number, 71,937 of them were discharged, while the death toll stood at 1,267 deaths. As at this morning, the total cases in Nigeria stand at 158,042 cases. Mortality stands at 1,954, while a total of 137,025 people have fully recovered. COVID-19 pandemic has affected the whole globe and continues to alter the life as we know it. As COVID-19 cases soared in Europe, the United States, Brazil, and India, confirmed cases in Africa remained comparatively low. Of the number of cases, 8.5% of the cases were said to occur in children under the age of 18 years. Coronavirus, as we know it, belongs to the family of the Coronaviridae. There are, like I alluded to earlier on, the particular one responsible for this disease, this present disease, is the SARS-CoV-2, and it is an RNA virus. Presently, there are many thousands of variants or different versions of COVID-19 circulating. Apart from the Brazil variant, that is the P1, concerns focus on a few. We have the UK or the Kent variant, the B117, which is dominant in much of Britain. It has, however, spread to over 50 countries and appears to be mutating again. We have the South African variant, the B1351, which is found, 351, which is found in at least 20 other countries, including the UK. Like I told you earlier, there are over 1,000 variants out there. However, doctors currently recognize 7 types that can affect humans. And those ones are being watched closely. At this junction, it's also important to mention that the reservoir of the SARS-CoV-2 that is causing the infection presently is the bat. There is also an intermediate animal between the bat and the human, which at this point has not been identified. It has been stipulated that it has been said that it could be either a wild animal or a domesticated wild animal or a domestic animal, but it has not been well identified. On the home scene or on the home front, in Nigeria alone, there are about 54 strains of COVID-19, of coronavirus. However, focus is on the B117, that is the UK strain. About 29 cases have been isolated of that strain. Also, the B15525 strain, about 30 cases have also been isolated as at 14th of February. What exactly is the pathophysiology of this condition? The infection is via the aerosol droplet. For instance, if an individual or who is infected has cough, and as he coughs, the droplet spreads to another individual. This individual can inhale the droplets through the nostrils, and and it can settle there. The organism can settle there and invade the mucous membrane. Also, touching of contaminated surfaces and using the contaminated fingers to touch the orifices like the eyes, the mouth, the nostrils is also another avenue through which the virus can get into the human body. It has an incubation period of 5 to 6 days, but it ranges from 1 to 14 days. So when an individual inhales or insinuates this virus into the orifice and it passes through the mucous membrane, what happens is that it binds to the host cell receptor, the ACE2, via the subunit of viral spike protein. Then it moves on to undergo what we call conformational changes in the viral spike protein, which leads to penetration, giving rise to the viral and host cell membrane fusing together via the S2 subunit of spike protein. By the time this happens, it goes into what is called the viral, there is entry of the viral nucleocapsid into the host cell, which releases the viral contents. At this stage, we have what is called, when these contents are released, we have the release of interleukin-1, interleukin-6, tumor necrosis factor alpha, interferon gamma. This whole release is known as the cytokine storm. And when this happens, there is chemo attraction for the neutrophils, the CD4 cells, the CD8 cells, along with the B cells. They all differentiate and causes the sequestration of inflammatory cells in the lung tissues. When this happens, there is diffuse alveolar damage in the lungs, which will now give rise to what we call the acute respiratory distress syndrome. When this occurs, it has been noticed that it is usually fatal in the elderly, particularly people that are over 60 years of age. It may be fatal in people with underlying medical conditions such as diabetes, people with underlying conditions such as cardiovascular diseases, chronic respiratory diseases, and cancers. The risk of severe disease increases gradually with age, starting from the age of 40. Now, when this situation happens, usually there will be an amplification or a manifestation of certain clinical features, which by now we are all conversant with. And those symptoms are the common symptoms of fever, cough, sore throat, fatigue, headache, shortness of breath, muscle pain, loss of taste or smell, nausea, vomiting. You can agree with me that all of these symptoms are non-specific symptoms that can be found in other common ailments around us. Having said all of this, it is important to note that there are a number of people that may have this, that may be infected, but may still be asymptomatic, meaning they will not show any of these clinical features. And it has been said that SARS-CoV-2, there is a portion of people that, though may be asymptomatic but will still transmit the disease. So being asymptomatic does not automatically mean such an individual cannot transmit the disease. No, one may be asymptomatic and still transmit the disease, particularly to us suspecting individuals. The clinical spectrum could be that of a mild disease, and this occurs in about 40% of infected persons. It could be moderate. It can also be severe. Now, of this severe group, there is a 5%, 5% of these people may turn out to be critical. And this group are the group that usually need medical oxygen. Now, this medical oxygen is important to help them to breathe better and also to prevent them getting, deteriorating to the point of getting intubated. How do we manage this COVID-19 disease? First, we need a high index of suspicion. Now, this high index of suspicion is particularly important in the hospital setting, where a physician or a clinician can be treating an individual for a particular ailment, and the result or the outcome of the treatment is not commensurate with what is expected. In such a situation, the clinician with a high index of suspicion will likely request for a COVID-19 test. And in most cases, when this has been done, it has come out to show that such individuals actually have COVID-19. Then, of course, history is very important. History of travel, particularly in the early days when the disease was when the outbreak first happened. History of travel from a region where the disease was already established was very important. Or history of travel from a state where the disease has already been isolated, where people with the disease have already been discovered or isolated is also very important. However, as we know more about the disease, the parameters we use vary as we know more about the disease. History of contacts too with persons that have the disease or have had contact with people that have the disease is also very important. Then, of course, history of symptoms is also very important. Of course, examination is also important. Taking of temperature, it has been known that people with COVID-19 have a very high temperature, up as high as above 40 degrees centigrade. Then, of course, having done all of this, the next stage will be to carry out the investigation or COVID-19 testing for a proper diagnosis. And this is done using the polymerase chain reaction. However, presently, the rapid test kits is being deployed, particularly in communities, to ease testing. When an individual has been diagnosed with COVID-19, a number of things can be done. If the patient is clinically stable, such an individual can be placed on self-isolation, particularly such a person can be placed on self-isolation while contact tracing begins to be able to trace all those who were in contact with the person in the last 14 days. So based on that, treatment can be either home-based, and in some states, home-based kits have been developed and being used for people that are being treated at home on self-isolation. And of course, we also have those taken to the isolation center for monitoring and for observation, monitoring, and also for treatment. The treatment is mainly symptomatic. That is, you treat the individual based on what symptoms the patient is manifesting. Then, of course, there will be supportive treatment to assist the patient's immunity to combat the disease. In established centers, there are protocols or cocktails that are being used, which may include antivirals, the popular hydroxychloroquine. In Nigeria, in Nigeria, people have also talked about using the ivermectin. However, I believe when we listen to the speaker that will talk to us about the local experience, some of these protocols will be made clear to us. Then, of course, for those in isolation center, there may be need for medical oxygen, particularly for critical cases. And of course, some people may even benefit from intubation. A number of complications have been highlighted, like lung scarring, multiple organ failure, neurologic deficit, and of course, death. Prevention is very important. Going forward, breaking the chain of transmission is at the heart of curbing this disease, and prevention is key in making this happen. How we can make this happen is by good hygiene. A good hand hygiene, regular washing of hands for at least 20 seconds with water and soap. Then, of course, sanitizing the hands with alcohol-based hand sanitizers. And of course, keeping surfaces clean and sanitized. Other things we can do, apart from the good hygiene, is wearing of face masks, plus or minus face shields, covering of one's cough or sneeze. However, if it is not possible to cover one's cough with a tissue, it is advocated that one can sneeze into the elbow or the crook of the arm. Social distancing is also very important. What is the way forward concerning this COVID-19? The way forward is vaccination. To be able to curb this infection, we must vaccinate massively. For good uptake of the vaccine, it is important for the people to understand the vaccine and also understand the reason for the vaccine. And that is the main reason why this webinar is taking place today, so that the speakers that will come after me will educate us about this vaccine and the need for it. The first batch of COVAX AstraZeneca Oxford vaccine arrived Nigeria on Tuesday, 2nd March 2021. Vaccination has started. It started at the National Hospital Abuja with 4 health personnel on the 5th of March 2021. This here in this picture is the index or the first person who had the COVID-19 vaccination, and his name is Dr. Cyprian Ngom. He is the pace setter, and we believe that because of his action, many more people will join in. Today, being 6th of March 2021, our president, that is the president of Nigeria, and some designated officials will be getting vaccinated today. 4 batches of vaccines are expected to arrive Nigeria it is postulated or planned that these vaccines will vaccinate about 70% of the population by the year 2022. 3 batches are supposed to be exhausted this year, 2021, with the last batch to be given in 2022. There is what is called the TEACH strategy that is being deployed to make sure that the vaccine gets out to the people. The T stands for the traditional rollout. The E is the electronic self-registration of health workers, which is very important because as we speak, 3.9 million doses of vaccine for 1.8 million people were brought into Nigeria. E-registration is presently ongoing, and as at this morning, about 2.3 million people have already registered for the vaccine. The other parts of the strategy are the concomitant vaccination, which will be going alongside the e-registration of the general population. And then of course the H stands for the house-to-house teams that will be deployed specifically to areas where there is poor enrollment on the platform. In conclusion, I would like to say that since the arrival of the vaccines, there's been talk of people not taking the vaccine or not wanting to take it from many quarters. However, the decision to reject the vaccine seemed to have stemmed from faulty reasoning. This webinar will help us to learn about the vaccine so that going forward, our decisions can come from a place of knowledge, which will enable us to make the right decision. These are my references, and thank you all for listening. They're highly appreciated. Hello, Olalekan.
I can hear you. Thank you so much. Thank you so much, Dr. Margaret Pokuola, for that wonderful overview of COVID-19 virus. And I'm definite this has gone a very long way to set a pace of what this webinar series is all about in the mind of our participants. And from this very introductory segment, we've been able to understand that there are quite a number of variants to this virus. However, what our focus is today is that which hits the world the most and that which relatively concerns us. We've also been made to understand what the current statistics is like. That means this virus is still very much available. And also we've been able to, I mean, from the last part of your presentation, saying to us that individuals are refusing to take these vaccines, available vaccines for faulty reasons. And I mean, just to say that individuals who have questions can begin to note down their questions. If you want to ask them now, it's fine. You can just unmute yourself and ask these questions. And also, alternatively, you can drop your questions in the chat box. But once again, I want to say thank you to Dr. Margaret Pokuola, the Executive Director, CHELP Nigeria. Let it also interest me to say that she holds quite a number of leadership positions. And yeah, she's one of my woman mentors here in Nigeria. And in the world at large. So thank you so much, Ma, for what you do for humanity. And thank you so much for making this webinar series a reality. So I don't know if there are questions, we'll be willing to take them now for this first section. So while we wait for questions from other participants, I think I can go ahead to shoot first. I have a question for you, Ma. For the sake of individuals who would necessarily not understand in depth the medical pathology of this virus, can you just in brief give us 1 or 2 reasons as to why we have variability in the expression of the COVID-19 symptoms in individuals?
So please, can you come again?
I said, can you just briefly, in summary, give us an overview of 1 or 2 reasons as to why we have variability in the manifestation of COVID-19 symptoms from individuals to individuals?
Okay. From the pathophysiology that we discussed, once it gets to the stage of Hello.
Please go ahead, Dr.
Okay, fine.
Yeah, please go ahead, Dr. We can hear you.
The pathophysiology. Please, can you take the question?
So I said, could you just give us 1 or 2 reasons as to why we have variability in the symptoms being presented from individual to individual? I mean,
okay, variability.
Yeah, I mean, why do we have variability in individuals who actually present with this virus? You could have someone who is actually going to be asymptomatic throughout the process of infection. However, we could also have some persons who would manifest very, very severe symptoms of the COVID-19 vaccine. So could you just give us 1 or 2 reasons as to why this is so?
Okay, thank you very much for that question. When I talk about the clinical spectrum, I meant that it could be mild, the moderate, it could be critical. Now, some people are asymptomatic, as we've already said. It could be as a result of their immunity. I believe that the person that will talk to us about immunology may touch. I believe strongly that it could be a function of their immunity. Then also, I mentioned that the elderly, it is more severe in the elderly. And this is not far-fetched as people age, their immunity is no longer as strong as it should or as it was when they were younger. So they are more susceptible to this disease. Also, they are in the age group where they may have 1 or 2 coexisting morbid conditions, premorbid coexisting illnesses. For instance, I talked about people with diabetes and also people with cardiovascular diseases. So having some of these comorbid conditions may make them to be more susceptible to the disease, and they may manifest it more severely than others. It has also been shown that in children, just about 8.5% come down with the disease. And it has even been found that in younger age group, they are still susceptible to this disease, but they may not come down with it like the adults. They are more protected, so to say. I don't want to say that it is the function of their immunity, but maybe the person talking about immunity will help me with that when he comes up to speak. But studies have found that the children do better, and it has even been advocated that children from the age below the age of 5 can stay away from using the face mask, and even not using the face mask will not predispose them unduly to getting the COVID-19. I don't know if I've done justice to this question, but as other speakers come up, they can throw more light on it. Thank you very much.
Yes, thank you so much, Dr. Margaret Popola, for responding to that question. And like you rightly said, as we continue in the course of the webinar series, subsequent facilitators will do well to shed more light on that question. So thank you so much. So
Then
if there are other questions,
if I can just chip in one more thing.
All right, please go ahead, Doctor.
Yes, it has also been found that people, the hypertensives that are on vasoprine do better when they come down with COVID-19. It is believed that the vasoprine gives them an advantage or a kind of protection. So their symptoms are not as bad as people with diabetes, and they do better generally when they get COVID-19. Thank you.
Okay. Thank you so much, Doctor, for that information. So it means individuals who are currently being managed for some underlying health conditions could also actually have some, they could have milder presentation of the symptoms compared to individuals who are not on any current medication. So thank you so much for information. Because of our time, to take us further in today's presentation, we'll be having the next round of today's lecture by Dr. Solomon Rotimi. I want to say a very big thank you to you, sir, for accepting to be a facilitator at this webinar series, even at a short notice. So Dr. Solomon Rotimi is an associate professor at the Department of Biochemistry at Covenant University here in Nigeria. And he's a one-time Fulbright visiting scholar at the Department of Translational Genomics, USC Kent School of Medicine in Los Angeles. He's currently the Director of Translational Research, Prostate Cancer Transatlantic Consortium. He's also a West African Principal Investigator for the CAPTC Clinical Proteomic Tumor Analysis Consortium, and also the co-chair for IOTIC Research Committee. So thank you so much, sir, for being on this webinar series today. And right about now, I'll do a play of his recorded presentation. Today is here with us. So after this presentation, you can do well to ask your questions and we will respond today. So thank you. Just give me a minute. So Dr. Margaret, can you unshare your screen? Can you stop sharing your screen?
Okay.
Thank you. Okay. Sorry, a minute.
Yeah. It's done. Thank you.
All right. Thank you. Can you hear me? Can you hear the recorded video? Hello, are we together? Hello, sorry, are we together? Can we hear the video?
Yeah, the audio is not out.
So I sincerely apologize. I'm trying to figure out what the trouble is.
Mr. Ladimeji, do you hear the audio yourself?
I can't hear the audio yet, so I'm trying to figure out what the trouble is. I can hear the audio without having to put it up, but I'm not sure what the trouble is with doing that now.
Okay, so okay, so let's do it this way. So if you could hear me and everybody can hear me, I will speak to it. Okay, no problem. So once again, thank you very much, everyone, for having me. I'm so much excited to be part of this. It's my pleasure to speak to you today. Sorry, I couldn't really join live. I have a family and so I'm speaking to you from my phone. So I've been invited to speak to molecular biology of COVID-19 vaccines, and earlier on. So earlier on, I sort of TV and I heard what Dr. Margaret talked about, giving you a clinical background about what COVID is. And so, because the most important part of COVID, if you could just put it forward to the next slide, yes. So if you basically look at what COVID is, such a challenge that, like other medical challenges, we usually look out for easy way out. Nobody really wanted doctor, nobody wanted to be suicide. And so the best thing for us to turn to is what has been considered to be perhaps the most outstanding public innovation as far as health is concerned. That is vaccine. And talking of vaccine, historically, vaccines have been very useful for us in controlling many diseases. Initially, was thought of it to be useful in controlling typhoid diseases, but we now know that we have vaccines for several diseases, even these affected heart. An example of that is cervical cancer. So we have now vaccines that are used to prevent cervical cancer. So the utilization of vaccine has gone beyond typhoid medicine. And next stage. Okay, so the question then is that let's go down the history lane a little bit to have a better understanding of what vaccines are. So the history of vaccine, of course, went back as old as you can think of human record, but then physicians started to realize that smallpox in a survivor will not develop disease again. And so something happened that when they have the disease, they don't develop it again after the first episode. And thus, the method of variation was started. But sometimes in 1755, a strong connection was drawn between smallpox and milk-made cowpox, particularly looking at women or who take care of cows and milk the cow. And when the cows have cowpox, the ladies sort of develop against smallpox. And so the person that actually went ahead to establish that was Edward Jenner. And what Edward Jenner did was to take the pus from a milkmaid and injected it to a gentleman by the name James Field. Okay, and then of course James Field developed some mild symptoms, and after that, Edward Jenner passed another injection of the same pus, and then realized that James didn't have any symptoms again. And so that developed what we now refer to as vaccine. So if you look at the word vaccine, it's from the Latin word vacca, which simply means cow. Next slide. Yeah, so the next slide, I think I'm taking you through the history, a little bit of history of molecular biology. Remember the topic is aspect to molecular biology of vaccine. And so the history of molecular biology again itself is big and it's a huge history, but there's part of it that I think is relevant to us was the experiment conducted by Frederick Griffin, who Frederick moved rapidly to like where the next that I summarized experiment. So what Griffin did was what we call in molecular biology transformation principle, which means there are two varieties of the bacteria. One is raw, the other is smooth. Okay, one causes the disease, and the other does not cause it. Please move forward. Okay. Yeah. Just the whole of that page. And so what you then notice is that the raw bacteria is non-virulent, while the smooth one, is virulent. Okay, good. And so what it did was they injected, the raw non-virulent strain to mice. The mice, was healthy, but that's the non-virulent strain. And then the next one it did was to inject the smooth virulent strain, and the animal died. So when the animal died, it then took that smooth bacteria, killed it with it, injected it to the animal, nothing happened to the animal. So he then took the heat-killed bacteria, mixed it with live non-virulent, injected it to the animal, and the animal died. So from that experiment, molecular biology came to the understanding that there is something in the organism that kills. That thing has the ability to kill when it is a live organism. And it doesn't matter whether it's a parent organism or in a surrogate organism. Right. So which means the substance that kill is somebody saying you can hear the audio now. So does that mean I can stop speaking?
Yes, sir.
Okay, I can stop. Okay. Go ahead. Thank you.
All right. Sorry, Dr. Solomon. It's like we still need to continue with the way we started.
Okay, so you probably just want to also, if we then say that there are several compounds, there is a compound in the animal, or sometimes the animal that's able to kill. Whether the substance is the parent animal or the parent organism, I don't know, or you move it into a surrogate organism. The question then becomes, what are different compounds that we have in a living cell or in an organism? Basically, there are about 4 groups. Okay, we have the group that we refer to as protein. Okay, so when the previous speaker talked about spike protein, that is a protein. Okay, there are those that are referred to as fatty acid or phospholipid or lipids generally. There are those that we refer to as carbohydrates. We all know what carbohydrates are. And there are those we also refer to as nucleic acid. These are DNA, RNA that we refer to as nucleic acid. And so when we say that there's something in an organism, that thing could be any of these. And so which means if you are trying to develop something to represent a parent organism, you could use any of these 4 compounds. Next slide. I just okay. And so the question then becomes, how do these compounds, these four classes of compounds relate? So in molecular biology, we call it central dogma biology, which is that you have the DNA as the information reservoir of the organism. And then that is the DNA. That DNA is in the nucleus. It is transcribed into an RNA, which is also a nucleic acid. That RNA moves out of the nucleus into the liquid part of the cell, called the cytosol, cytosolic environment. It is in this cytosol back through a process that we call the fast transcription. So which means, for example, if you are interested in carbohydrate ending, you can actually take